Hello, I'm Mark Rickenbach. I'm a GP near Southampton and a Professor of Healthcare at Winchester University. And we're talking about the heart-sink feeling in consultations and how we might try to overcome this and help our patients. And we've got a team here which is involved in the Continuity of Care Health Foundation programme, which took place over the last 2 years in 5 centres across England. And all of us have been funded as part of this Health Foundation Continuity of Care programme. And the heart-sink feelings have come, or rather the consultations related to heart-sink feelings and the comments about how to handle them have emerged from the toolkit, which is available for you. So heart-sink feeling. The picture there is by Rebecca Hawkin from Australia, and she's agreed to us using her picture. And what I want to do is get you to think about your consultation as a patient. Now, bearing in mind you're a healthcare professional, so the pressure might be on a little bit for someone like a GP or a healthcare professional colleague who is seeing you. On top of it, think about the possibility that you might have multiple different conditions, and perhaps you might be depressed. And then think about whether you might cause a heart-sink feeling in someone who was looking after you. And if you were known as a heart-sink patient, would that be something that you'd feel uncomfortable about? And might it just tip you over the edge if you were on the edge anyway? So I think the heart-sink feeling is a better way of describing it than the heart-sink patient. That was a term coined by Tom O'Dowd in the BMJ in 1988. And he tried to classify patients on this basis. But I think the feeling is owned by the healthcare professional, and you as a healthcare professional can change your attitude to it and feeling to it. You can convert it. So we'll talk about heart-sink feeling or heart-sink consultations. And the emotion that you feel is actually a cue in the consultation. In the same way as if you feel anger in yourself in a consultation, it means the patient may be angry. If you feel depressed in yourself for some reason, it may be the patient is depressed. So they're cues that you can pick up. And the first suggestion that emerged from the Continuity of Care programme was to think about what is actually making your heart sink. What do you think is going on in that consultation? And it may be that there are unrealistic expectations here, that the patient or possibly yourself have unrealistic expectations. There may be too many problems actually in this consultation, and it needs to be staged to take the pressure off. Or it may be there's a hidden agenda and something you don't know about that you need to explore a bit more to find out what the key is, what the clue is. It could well be that it's outside your normal prescribing or approach. You're being asked to do a CT scan when you think it's inappropriate, or give a medicine that you think is inappropriate. And it may be that the transactional analysis between you shows that one of you is the child, and it may be that it's the patient, or it may be that it's the doctor. And one of you may not be listening fully or believing what you've heard. And again, it could be you as the healthcare professional or the patient. So think about it both ways. We have found that it helps to discuss approaches with colleagues. Think about what's making your heart sink, and then discuss how you might voice this issue in a consultation and somehow reflect it back to the patient so that you can perhaps manage that aspect of it better. The next thing that seems to help is trying a longer consultation, and perhaps starting with asking about themselves or their past or their family, because this sometimes unlocks the feeling and gives insight to what's happening in their life. And I found that often that resolves that feeling. There is something about longer consultations, and elsewhere in the conference I've talked about 20-minute consultations, and it does make a difference to be able to have that. But setting aside a double appointment, or perhaps even longer, will help you. So this came out of the Continuity of Care project. And the thing about continuity of care, as you may have heard in the Times newspaper this week and from the Norway study, is that there is extensive research which shows that continuity, seeing the same person over time, reduces mortality, morbidity, emergency care admissions, And it increases satisfaction for the GP and the patient and the staff. So the Health Foundation Continuity of Care programme showed ways to increase continuity of care despite the national fall. It reported that in certain areas there was a reduction in workload and increased patient access. And in one particular area, Peer Health in North Somerset, they developed a system for helping people who were in that difficult situation of having challenging consultations where the health professional had a heart-sink feeling. They set up with the Red Cross a high-intensity user service, and the leaflets are phrased so that actually it looks like they're giving extra support for those individuals, which they are. And in fact, some of the work that's going on is very similar to the social care or social care prescribers or social care link workers, which are set up in most practices across the country, thanks to the additional roles and the primary care networks. They also noticed that as well as the high intensity user service, that having clinical meetings to discuss patients who were inducing that heart-sink feeling in their professional doctors helped. So the heart-sink feeling is owned by you, yourself, and therefore you're empowered to change it if you want to. The feeling can be overcome or minimized to the benefit of you as a healthcare professional and to your patients. And there are now approaches to handle a heart-sink consultation which do help. So I'll pass on to you for questions and thank you for your interest.